So I hope everyone had a good lunch. Welcome to the first afternoon breakout session. I'm Dr. Andrea Mucci from Cleveland Clinic Children's, and it's my absolute pleasure to be facilitating today's breakout session on building equity through social determinants of health. We have a number of exciting speakers with us today from Kansas City, Cincinnati, Texas, and NY in New York. And to be cognizant of time, I know that Ori is going to hold up a sign at the beginning. So each speaker will have 10 minutes. When she holds up the 5-minute sign, that means your time for questions has started. So if you would, you can prioritize your time in terms of completing your slides versus giving more time for discussion, because I know that in this morning's session, we would have all liked a few more minutes to ask questions, but I'll be obviously up to the speaker. So I'd like to invite our first speaker, Emily DeWitt from Children's Mercy Kansas City, to come up and give us our first talk.
Thank you so much for having me here today. I'm the Quality Improvement Manager at Children's Mercy, and I oversee a team of 10 fantastic professionals who split their time between quality improvement and research. A couple of our quality improvement specialists also have their foot part-time in the clinical space as well. So today I'm going to talk to you about how we've been addressing social determinants of health to improve outcomes for our patients with diabetes at Children's Mercy. I have no disclosures or conflicts of interest. So where is Children's Mercy Kansas City? We are located actually in the state of Missouri. We have a hospital on the Kansas side as well. We also have the Children's Mercy Research Institute, which is pictured here in the middle in the lower corners. We've got some dedicated workspace for some of our endocrine staff there. We serve about 2,400 patients with type 1 and type 2 diabetes combined. We've got 14 clinics now spread across both the states of Kansas and Missouri combined. And we've got about 50% of our population is on private insurance and 46% on public and 3.5%. There we go. Thank you. Okay, so we started this work back in September of 2021, prompted by the recommendations from ADA. Our aim was really to just implement a social determinants of health screening tool into our clinics and analyze the completion rate, this positivity rate, and then look at that data by race and ethnicity as well. We pulled our survey from the Accountable Health Communities tool, and we added a question from the Prepare survey to also ask families about their desire for assistance for social determinants of health type needs. Again, we put this in our intake form, so that is sent by RedCap, and that goes out to families about 3 days before standard of care clinic visits. So everybody was receiving that either through email or text message. We first started responding to positive screens by sending families a resource sheet. You can see the stiff images of it here. As I mentioned, we straddle the state line, so it can be really kind of tricky to navigate resources in the Kansas City metro area. But this was a starting place for us. Then we quickly, after our first test of change, we're putting this into our electronic health or our intake form, we realized we needed to automate the process of sending that out. So that was our second test of change. Then we did not get a lot of families to fill up from a survey, because in addition to getting that into our intake forms, we had a survey going out 10 days later to just check in with families and see if that resource was helpful with meeting their needs. Didn't get a lot of feedback from families in that way. So some folks on my team started just doing phone calls to try to reach those families. Unfortunately, that wasn't very successful either. And so luckily at that time, we were introduced to a new resource for us called Lift Up KC. And this is a really comprehensive database full of community-based organizations in Kansas City. Users can just put in their zip code, and in just a matter of seconds, it populates with lots of resources. There's lots of different filters. This is obviously a screenshot of what that looks like. So families can find everything from food resources, housing, even things from education, employment, health, all of those types of things very quickly. We had folks on my team follow up with those positive screens who also indicated they'd like some assistance with navigating this resource. We also gave families some options as to whether they wanted to just lift up Casey on their own. So some of our other tests of change, I'll just highlight a few here. Again, we flip-flopped with some of those selections on whether they wanted help or not. We added in some built-in notifications to our social workers because we realized that oftentimes they were really best equipped to handle really high-risk situations. They named that as being, times when families were actively homeless or they've had their utilities shut off. We also noticed that in general, our positivity rates around cycle 8 were pretty low. We expected them to be higher than the 2% that they were at that time. And so we modified our language at the start of the survey. So we gave families some context as to why we were even asking the questions, gave them some rationale, and just point out the fact that we recognize that when basic needs aren't being met, that it's really hard to manage diabetes. So we made that connection for them. Also, we made it clear that if you had us help you navigate these resources, that was a free service. And about 11 weeks after we did that, we saw about a 3% increase in positivity rate. So we think that that language and that clarification is likely to have impacted that number. We also added in some clarifications on who should be completing the survey and did some other just process updates. So here you can see our completion rates varied anywhere from 49 to 73% across the span of time from September of 2021 to July of 2022. You can also see that our positivity rate varied anywhere from 2 to 10%, although it's important to note that 10% was just that one day that we first got that survey into place, so it's not very representative of the whole time frame. We also consistently were seeing that utilities and food assistance were most commonly requested, and that was consistent throughout the time. So here you can see our completion and our positivity rates broken down by race. So on the left, you can see here that 79% of our surveys were completed by whites in our clinic, but yet they only made up a much smaller fraction, 43% of the positive screens. Then in contrast, you can see that only 8% of the surveys were completed by Blacks, but yet they accounted for a much larger percent, 27% of positive screens. So clearly there's a disproportionate number affected by social determinants of health. Also, here is our data broken down by ethnicity. So 88% completed by non-Hispanic and 84%, pretty close for positive screens, but yet Hispanics clearly have a much higher affected rate from 9%, but yet being screened at 15%. So some of the things we are looking to do in the future is to add a provider alert for positive screens. We've had a few technical difficulties with it. We've been able to pull in the survey results so the provider can see that at point of contact. And we've also had some postcards added so that lift up Casey information can be printed out on a postcard, both in English and Spanish, and that can go with the DPART papers. We're looking to collect some health metrics like hemoglobin A1C, DKA rates, and look and see how that those metrics change for those that we helped versus those that we either couldn't reach or declined our assistance. We've also talked about moving that screening survey to the beginning of the intake form. Completion rates, we think there's some room for improvement there. And as I mentioned, there are quite a few surveys in that intake form, and we think by moving that to the top, we might reduce survey fatigue and get a few of those answered. We also really want to engage some community partners with a focus on the minority groups who are disproportionately affected. We're really fortunate to have a strong partner in Kansas City named El Centro, and they do focus on the Hispanic population. So that's good, but we're still looking for other partners. And we've already had these surveys translated into Spanish, and they are in our language services for final approval. So that will be going live soon. I want to acknowledge all the wonderful people that have helped make this work possible. All of this was made possible by the Rising Tide Alliance, which is generously funded by House and Charitable Trust.
Are you using an existing tool for the survey? Is that
Yes, that makes sense. Yes, it comes from the community health tools that was, and then the prepare question around their desire for assistance. So it's validated. Okay.
What percent of your population is right platform? I'm just thinking like this being electronic and you're kind of people who may not have services and things like that. Or are you reaching who you think you need to be reaching and wanting to reach?
I would say in general, all surveys are probably around 65 to 75% at any given time. That's a really, important question we've kind of pondered and thought about, because clearly we are missing some folks that aren't even getting that survey answered.
Would you be willing to share the wording? I love that you made sure they know that it's confidential.
Absolutely. Yeah, in fact, we had our health literacy committee review that language as well, just to make sure it was written in really plain, easy to understand language. But we'd be happy to share that.
I was just going to say something about earlier question before the product. I love the list of KC website. And so I think you talked about this before when I was on a meeting. And so I looked it up and it's actually part of what used to be AMP-HRSA. It's the public health. So you can actually use that same website for anywhere in the nation. It's a super great resource. I know I shared it with our social work team when you presented about it, and they were like so excited about it.
Yeah, it is absolutely amazing. And we're actually able to get to the website through Cerner now. So that's all integrated. When we very first started, it wasn't that way. And we love that because we can really track the data, but we do offer families just out of respect of privacy if they want to navigate on their own. But when they go through the public facing website, there's no way of us tracking that data, but I think it's worth it.
Great. Well, thank you so much for that excellent talk. Much for a round of applause. Thanks again, Emily. Next up, we have Dr. Nana Jones, and she's going to be talking about the implementation of social determinants of health screening in diabetes clinic, and she comes to us from the Cincinnati Children's. Thank you, Dr. Jones.
We're all navigating this cord so we don't trip. All right. Hello to everybody here in the room and those on Zoom. So I'm going to be presenting implementation of social determinants of screening at Cincinnati Children's Hospital. I am Dr. Nana Hawa Yaya Jones. I'm a pediatric endocrinologist at Cincinnati Children's Hospital. I have the pleasure of working at a very large center. We see about 2,200 patients with type 1 diabetes, about 200 new onsets. 70% of our patients are privately insured, and about 20 to 25% have Medicaid. And we even have some unlisted and self-carry patients as well. We have a robust education team that even includes a psychologist, clinical specialist, data analysts, and of course our families. So everybody here should be familiar with the background of the type 1 diabetes exchange and the change that we've made with quality improvement projects over the years. So since 2017 to 2018, you've seen a reduction in A1Cs across all populations and all ages. And Cincinnati Children's Hospital is no stranger to those changes and successes in population management since the implementation of quality improvement projects. However, there still remains significant morbidity and mortality for certain populations, especially our Black and minority patients. So locally, Black patients with type 1 diabetes have higher A1Cs, lower rates of diabetes technology use, and higher rates of hospitalizations. And so, of course, we hypothesize that some of the social determinants of health are what attribute to those gaps that we see and the lack of successes that we see in those reductions in population management within specific populations. So we went about trying to implement social determinants of health screening in our diabetes clinic. And this started as a quality improvement project in one of our I2, S2 classes that's given by our Anderson Center, which is our quality improvement product at Cincinnati Children's. And really our goal was to use quality improvement methodology to implement screening. And our goal was to increase screening from 0% to over 90% by the end of June of 2022. Of course, you guys are familiar with quality improvement. So we use the, Plan, Do, Study, Act. And what you're looking at here is our social risk questionnaire. One of the things that came out of it was our next best document. So what's the next best thing to do after you screen, right? So it's not just important to screen, but what do you do next when you have a positive screen? So of course, with any equality improvement project, we start with our key driver diagram. And we really had key drivers in multiple categories. Those that were patient-centered, those that were community-centered, and those that were actually system-centered. I think this is an error on this presentation. It's actually system-centered. So we really went from the top down and from bottom up, making sure that our interventions matched each one of those key drivers, including a multidisciplinary clinic for patients that are deemed to be vulnerable. We implemented, again, the social determinants of health screening, even during telemedicine when we all went remote. And then we even have a second tier, third tier on how to tailor standardized treatment plans when needs are identified. And at the earlier session, if you guys were in here for the technology talk earlier, they talked about a CGM champion. Well, we had an SDOH champion. So we had clinic nurses who are SDOH champions that probably single-handedly help to improve uptake of SDOH screening in clinic in real time. All right, we were very successful in increasing our SDOH screening in our population in our clinic, going from 0% to greater than 90%. And as of September of 2022, we had completed over 5,000 screens. We had shifted the center line up to nearly 90%. And then, of course, the next question is, well, what was your outcomes? And we, like Emily, actually saw probably about a 5% hit rate. So up to 5% of our population screened at least one social determinants of health screening. And as you can see right here on my left, you can actually see the percentage of positive screens by question. And if you take a look, you can see which ones were the highest hit rate, and probably the highest one actually was number 10, which is, has anything bad or scary happened to you or your child since the last clinic visit? And this was actually a very insightful question because it was prose. So if you answered yes, you actually got to type in what had happened. And, you know, a positive patient story, and I had gone into the whole visit, didn't know anything was going on, ended up looking at a social determinants of health screen and found out that grandpa, who was a primary caregiver, had died the previous month. I mean, something very important to know in a diabetes clinic is something I probably would have never found out in intake had we not screened for that. The other positive screens that you can see, of course, are food insecurity, you know, saying sometimes true, not having enough money to get more groceries. And then you also see problems with benefits such as SNAP and food stamp, daycare vouchers, SSI, medical cards. There's a 1% positivity rate for housing problems. We actually have a very robust legal aid help program that I can't go into details about that today. But we were able to really look at our positive rates, and we will also be looking at it by demographics and by race, but we don't have that data for you today. All right, so what is the impact of our work? So we really started out with pen and paper. I said the journey of 1,000 miles starts with one step. So we literally had an SDOH screen on paper and delivering it to patients. And then we began to do tablet screening using our primary cares questionnaire. So Cincinnati Children's Hospital is a very big hospital. We have a primary care pediatrics, and they had been doing social risk questionnaires for a long time. And they had already had it fired on tablets. So literally all we had to do was turn it on for our diabetes clinic. And so our patients were able to answer those social risk questionnaires on the tablet when they checked in. And then what we've done now is actually integrate that into the electronic health record, which is EPIC. And so EPIC actually has a social determinants of health screen. And so now as a hospital-wide initiative, all our patients will be getting social determinants of health screen in different primary care and specialty care services. So we actually, as a diabetes center, laid the groundwork and the foundation for the workflow for that social determinants of health screen hospital-wide. I have said it before on different meetings. I don't care where my diabetes patient notes that they have housing insecurity. They could be inpatient, they could be in the emergency room, or they could be in diabetes clinic. And as we know, we have high no-show rates. So sometimes that 5% positivity hit rate may be really the fact that I can't screen because they're not in clinic because of that social determinants of health. But if they're showing up in pediatric primary care, if they're showing up admitted, if they're showing up in the emergency room, now we have the opportunity to screen those patients using our electronic health record. And we went live with that on October 18th. And then adolescent medicine will be following. So we're doing a systematic rollout of hospital-wide social determinants of health screening. All right, so our key learnings, the SDH champions is a huge one. The on the ground clinic nurses who are really passionate about that work and getting their peers and colleagues to uptake it as well. Sharing success stories. So one of the success stories that came about was a family who had housing insecurity and food insecurity that had never divulged it before. And once the screener came out and they were able to anonymously kind of identify just on the paper, and then our social worker was able to actually give her a Kroger gift card, her entire demeanor and attitude changed right there in the minute, in the hour in diabetes clinic. And that built a trust and relationship that's probably cannot be quantified. And using that success story really accelerated momentum for continuing to screen in that clinic, because that had been a patient that had been a lot of mistrust and discord and inappropriate language. And so that relationship was built just with a Kroger gift card. All right, so of course, automation is the key. So yeah, we started on paper, right? And so that was only as good as paper can be. And that was really level one, just relying on a kind of human factors, hard work, intelligence, and vigilance. And then we built it into the system with our social risk questionnaire that we had borrowed from the pediatric primary care. And now we're doing patient-reported outcomes. So in our diabetes clinic, we have a lot of questionnaires that we ask, right? We ask about barriers, we ask about transition. We even use the PHQ-9. So using that same technology, we are now asking the social determinants of health questionnaires, and we have a firing logic to help prevent questionnaire burnout. All right, so concluding, so implementation of social determinants of screen in diabetes clinic can be standardized and it can be effective, especially in identifying barriers for patients in needs with diabetes. And it can be rapidly adapted in other pediatric chronic disease populations, especially in a large tertiary care center, magnifying its impact on healthcare outcomes. Yeah.
Like I feel like we're so good at getting like endocrine buy-in, and then we're like, I love it anywhere they go with me, right? So you can find the problem when they're there.
Yeah, so the question was, how do we get institutional buy-in for our social determinants of health screener? And I'll be frankly honest, we became an affordable care agent. And so Healthline Care Source is a medical, a managed care organization that Cincinnati Children's is now the primary care home for. So we now take care of over 130,000 children on this insurance plan. And so basically it's top down. You must screen for social determinants of health in order to manage those patients. Yeah, and we built it through Healthy Planet too. Yeah. That's a very good question. And maybe I'll back it up to our one of the slides. So the first question was, who is the one that follows up with the social determinants of positive screens? So our next best document, and I know you can't see it, but you'll see it in the slide deck, basically kind of documents what is the next best question to then determine who do you refer to. So for instance, do you worry about food running out, right? So the question the provider or the nurse is asking is, have you applied for food stamps? Are you aware of the food pantries, at Cincinnati Children? And depending on what the answer is, we might refer to social work or we might refer them to the food pantry, right? So, and then, have you felt down, depressed, or hopeless? Like, is there active SI or HI? We have a robust algorithm for social work intervention for patients with high PHQ-9s. Is it, medical costs or transportation? Well, we have an Uber or Lyft program through our Cincinnati Children's Hospital. So then that's the next step. So it really does depend on what the answer is, where we send them next. But in the end, probably the primary burden of who is following up on the patients is our social work department. Oh, and in real time, yes, in real time in clinic. Now, of course, when we have occupational vacancies, just like everybody else, and time is strapped, we do have a social work pool that we can send the information to that can follow up afterwards if that's necessary. But typically we try to have it real time in clinic. The question was asked, when is the intervention? That's an excellent question. So the question was, how do you know kind of who's answering the questions? That some questions are targeted to the patient and some and the child, and some are targeted to the caregiver. And so how do we distinguish that? So we actually ran across that when we were first doing our social determinants of screening. So we added a question: who is filling out the questionnaire? And our expectation is it the caregiver or the patient 18 and over. That's who we expect to fill out that questionnaire. And that can get a little dicey because some of the questionnaires that we have that are getting filled at the same time are meant for the patient. So we are trying to create an algorithm by which we say, pass this to the caregiver now. So that they can pass the device on to the caregiver to answer the questions. So yeah, our expectation is the caregiver or the patient 18 and over. And we do ask who's filling out the questionnaire. Yes. That's an excellent question. So the question was about tablet burnout. Like, how do you know when you have questionnaire burnout, and what's our firing logic and kind of our firing rules? So when we did the social risk questionnaire, which is our pediatric-based social determinants of health questions, we fired it every clinic, every time, all right? But when we transitioned to the hospital-wide social determinants of health screening, we now fire it every 6 months, no matter where the patient is, all right? And so we do have a kind of robust firing algorithm that is running in the background, and our Epic Build team is what developed that algorithm. And we're still in their trial phases and making sure that it works right. So you have, if you're a patient that's being seen in this certain clinic at this certain time, and you haven't had the questionnaire in the last 180 days, when they check in, a tablet fires on the check-in person screen, and then they hand them a tablet, and then they walk back to clinic. Question, Shivani in the back. Right. So the question was asked about how you determine like who's kind of wordsmithing everything and making sure that which barrier is being addressed and by whom. And I think probably the end game is our social workers that circle back around to see if the intervention is complete. Now we do have, and again, it was beyond the scope of this talk, but we do have a very robust legal aid intervention where we actually partner with our legal aid Cincinnati City lawyers. And so a lot of times we're getting feedback from them, but typically the end game is a social worker determining if that barrier is, quote, resolved, right?
We have some questions from some of our virtual viewers. So the first question is, where did you get funding for the Kroger gift card? And the second question is, how does your social worker determine how much to offer in a gift card?
That's actually a very good question. I wish Molly Williams, our social worker, were here, because our social work department actually has a stack of Kroger gift cards. And then my collaborator and colleague and my partner in crime, Sarah Carruthers, who I believe is probably virtually, also had some funding from the Type 1 Diabetes Exchange during the pandemic to also offer Kroger gift cards. And then I also had an interdepartmental kind of a grant that also can fund gift cards as well. And I believe the other question about like how much was on the gift card, I think each price is set. I don't think it's different. I think it's a $50 Kroger gift card for each card that we have.
Thank you so much. I'm sure the listener appreciates that great answer. And thank you for your excellent talk. So next I'd like to call up Nurse Kristen Morrell from Cook Children's Texas, and she'll be presenting about the implementation of social determinants of health screening in patients with diabetes. Thanks, Kristen.
Thanks. So I'm Kristen. I'm actually the clinical manager in our department, our endocrinology and diabetes department. I have supervised about 30 clinical staff and then work to support 14 physicians and 4 nurse practitioners. We have about 2,100 patients with type 1 diabetes, and that's what we're going to be focusing on today. All right. So this is just my big plug for this key driver diagram and the work we're doing with the Exchange Collaborative. This has given us the tools we need and the direction to start doing the screening and the things that we weren't doing before we joined this group. So here we are working on screening all of our patients for depression, eating disorders, and social needs. just FYI, if you need to ever learn how not to roll out a program, ask me about rolling out depression screening at Cook Children's. I can definitely tell you all the things not to do there. So this gave us a great opportunity to step back and shift and do this correctly and roll this out in a manageable way. So as we all know, and we've kind of talked about with our previous programs, we all know that inequities in living, working, and environmental conditions have direct effect on the factors related to diabetes control. We were not doing any kind of screening at all before this. So we wanted to come up with a formal process for screening for SDOH in our type 1 diabetes patient population. So we just wanted to implement SDOH screening. So we started with food insecurity and we decided to go with the hunger vital signs. Our aim was to screen 50% of our patients over a 6-month period. So like I said, we decided to use the hunger vital signs. There's only 2 questions. One of the things that's really important to us is that it's a validated tool that we were using. And the other thing is it was already available in Epic. Those questions are already built into the EHR. So that's just one less thing we'll have to worry about down the road. I apologize for the typo. It's EHR, not HER. There, sorry about that. And like the previous team talked about, we just started with paper. Long term, paper is not necessarily going to be a sustainable option, but for now, we're going to start on a small scale, start with a piece of paper. And this screenshot here is exactly what was on our piece of paper. We sort of leveraged that, the pandemic and knowing that people have challenges. Because one of the things we anticipated was that people were going to have issues. Why are you asking me these questions? These aren't important. Why do you want to know this? So we just started, let's just ask the questions and see what we get. So we started with a small group. We had, the established diabetic appointment type, and we used 2 specific positions. So at the check-in desk, we gave them the piece of paper if they had that appointment type for one of those 2 positions. When they completed it, they handed it to the physician in the room, and then the physician notified the nurse that was helping them in clinic or the diabetes educator nurse who they were going to see for education if that was necessary. And so the nurse would document those responses within the medical record and then provide the resource. And our resource is a handout that was established for our neighborhood clinics. It had the information and some other local physical resources so that they could have access to. All right. There we go. So here's our results of our first cycle. It went over 7 weeks because again, we're new to this kind of thing and we're learning how to do it. But we ended up with an 89% completion rate. So, we're thinking we're doing great. This is good. But we had some questions. Are we going to get the same result if we expand this? Did we cover our Spanish speakers? Did our Spanish speakers have to answer the English questionnaire, which they did because we didn't translate it into Spanish, which is our second most spoken language of our patient population. And then why were some of the surveys not completed? So we added some questions at the bottom because we wanted to know whether or not completed. I think long term, that's likely not what we're going to continue, but we wanted to know whether or not completing it. And then we made it a double-sided piece of paper, Spanish on one side, English on the other. And we added one more physician to the group to cover our expansion. And then with our second cycle, our completion rate dropped to 70%. But we got some really interesting information about why it's not completed. Some people said they weren't comfortable completing it. Some people said, I don't think this applies to my visit. What does this have to do with my diabetes? Why aren't you asking about my ability to afford insulin instead of food? So that gave us some things to think about. So we wanted to see what we needed to do to increase it. So we wanted to expand it again. So we added a nurse practitioner to the group of patients that were being asked these questions. And we also added a statement underneath the original statement right before the questions to let people know that the responses will be kept confidential to help cover those people who felt like they weren't comfortable answering the questionnaire. And then it remained in English and Spanish, and our resource process remained unchanged. So we jumped back up again. We got an 84% completion rate this time when we expanded it. So this allows us this is kind of where we are now. So we've got some more questions. We learned some things. So this is something that's definitely sustainable. We can expand, we can apply to the clinic larger as a whole. We've been able to connect caregivers to resources and meet a need that we were likely not meeting before at all. we offered in both English and Spanish so that we can at least get those two populations covered. We definitely want to think about how do we expand to those languages other than English and Spanish. And then, our result support, we need to expand this to all of our patients with type 1 diabetes in our Cook health system. Now, our health system covers a very wide geographic area. So how do we provide resources for that area? Because most of our resources in our main department where we are doing this are local. We have some questions about how, you can't see it's covered up, but how does this full implementation of the Cures Act? I don't know if you guys are all feeling that pain of that implementation and everything being visible on the portal and the health record to our patients and families. How will implementation of SDOH information be affected by that? And then how well are the resources utilized? Are these good resources, or do we need to look at some other types of resources for families? If we expand this, if we continue to screen for patients, are we going to continue to see the same numbers of people needing resources? Or are we going to have people who are getting the resources and using the resources effectively? Therefore, that needs met, and they may not answer the same way the next time. And then do we continue to do this on paper? Or do we make this an electronic questionnaire as part of our pre-visit? How often do we ask it? It's built into Epic. So one of the things that we can do right now, it's kind of buried into the history section. So can we move it to the rooming tab? So do we ask it right when they're coming? Do we ask it as a pre-visit questionnaire? And how does it affect the system as a whole? Our Cook Children's system has a medical director of health equity, and she is working with a task force to implement SDOH screening throughout the entire system. So we're sort of leading the way for that. And so, she's actually been able to review the results to this very basic initial implementation. And then, what are the other things that we need to consider? How do the patient responses, how should we share them across visits? How do we deal with questions and issues and concerns where someone may not feel comfortable answering because they don't want, in a separated parent household? What are the implications of saying, from mom saying, oh, we're food insecure, and then dad saying, oh, look, I want my child because mom can't feed my child, and how do we handle those situations? So it brings up lots of questions, but we're starting to meet a need that we weren't meeting before. And in turn, hopefully we're better able to manage some of those issues with their diabetes. Right.
Do we have any questions in here?
Yeah. That is an excellent question. And at this point,
So the question was about people with maybe health literacy deficits and how to address that.
yeah, and those are great questions. We actually don't have a great answer just yet for that. We do know with our system implementation of SDOH screening and having that health equity medical director, there are some new programs that are coming. There are going to be some website upgrades. We've looked at that Kansas City website and really like that. And so we should have something like that coming soon as well. But again, that's kind of one of those long standing issues that we don't always have great answers for.
I have a question as
Yeah.
well. So one of the feedback from your families are, why are you not asking me about insulin? Have you considered actually including that question, or other social determinants of health in your questionnaire?
Yeah, so this is very implementation step number one for us. And we definitely want to expand to those other questionnaire types, the financial insecurity, housing insecurity. I believe financial and housing and transportation are also already built into the EPIC questionnaires. So we are, again, even with our organization, getting very early buy-in to addressing these needs and dealing with these things. So it's definitely on the list of things to do. Yeah, we have a long way to go.
No, you're doing a great job. Thank you. Any other questions?
But also, what about the provider after this? Because we have a study about we have our medical actually doing we're talking about those questions, and they have a lot of problems to actually talk to their families about that. So
Mhm. Yeah, so the question is sort of what do we do for our physicians and what kind of, I guess, sort of physician training is there to deal with answering those questions and having those conversations? We actually, like I have mentioned, we have our medical director of health equity who's very instrumental in us being able to implement that. While we have members of our team who are very familiar with social determinants of health, most of our physicians are not used to having those conversations, asking those questions, even, that being a part of their visit. So one of the things that she warned us about was these are going to be uncomfortable questions. You're going to have a very wide range of response from families, and you're going to have lots of different things you're going to need to respond to from the ones that do feel very strongly about this doesn't have anything to do with my diabetes. The doctor's not the one who should be asking that to, this is something that's very important and very serious and I need lots of help with it. So she's been very instrumental in sort of helping us with that. And one of the things that when we started this, I wanted to make sure that I had communicated to our physician team as well. Like, this is why we're doing it. This is what we're doing. But the other thing is we're being very discreet with our families too, as because I know one of the other things is that, parents may not want to have this conversation with the child in the room, especially in a pediatric facility. So how do we respect that for our families as well? So our approach has been to be very discreet with families. And if you have other needs, we definitely want to address them and can have our social worker follow up with you at a time where you're not present with your whole family. So you don't have to talk about how difficult it is for you to feed your family.
So one of the provider kind of trainings that we did was that next best document. So just helping to improve your confidence in following up with the question, because a lot of times it's just discomfort. Well, I don't know what to do, what the next step is. And so we provided that next best document. So when there's a positive training, what next best question to ask, and then what referral resource that you give. And we actually put it on a badge card. And so we gave it to all the providers so that they could see in real time how to do that.
And I think also, when they're answering the question, we found that if it's written, like they're more honest to actually tell you if they're having determinants of health, because if it's like they have to say it out loud, they might not like to. They're more honest and vulnerable if it's written or on a tablet.
Those scales were all goals to be self-controlled.
Yeah.
No one asked it to be honest. None of them had that. I was really people are asking them about this. We're putting the person in. I'm just so cool and not so cool. Yeah, and we're gonna do this. We can ask and be comfortable in the rest of the that's fine. And then we also another thing. We also have that. So the first question is, everyone's healthcare.
And just a brief summary for our virtual participants. The discussion was Dr. Jones from Cincinnati's talked about the provider training through the next step and how that's a useful enabling resource to let providers feel more comfortable bringing up these topics. And then we also had another note that these questionnaires are designed to be done as self-reported in writing and not to be a verbal discussion. However, if there are literacy concerns, that would obviously be something that the provider could address directly with the family or patient. Oh, okay. And I think we're out of time. So let's give a good round of applause for that excellent talk. Thank you so much for that, Kristen. And next, I'd like to invite up Janice Okowitz from Hassenfeld Children's, and she'll also be talking about improving social determinants of health screening. So thank you, Janice.
Thank you. So I am a nurse and a CDCES at HCH NYU. We work with a big team, but these are kind of the people that were the main project leads for our SDOH screening. So I'm going to say a lot of things that everyone else did because our PDSA cycles were all very similar. So again, we all know this, SDOH screening is super important. Diabetes is so tough to take care of. To have any other challenges just adds to, it will impact the diabetes management. So it was really important that we started screening. And of course, our push from the type 1 exchange was part of that as well. So we did do a baseline assessment to see how we were doing. And so I did a chart review for a year, and chose some charts to look at. And we did pretty poorly. We had 0 to 3%. And some of the ones that we did have, I think, were because of EPIC, the SDOH screening in EPIC, it had just been pulled in from another place that was screening. So one of our favorite things to do is kind of prepare for what challenges are ahead using our fishbone that Ori introduced us to. So we didn't have a policy, a streamlined process. We didn't have a tool. We didn't have resources to offer it if we did identify something. Our providers weren't trained. Our patients weren't used to answering this question. And it involved a lot of people. If we were going to do a questionnaire, the front desk, the educators, everyone really in the clinic. But our goal was to increase it from basically 0 to 50% in 1 year. So again, the main thing we had to start with was a tool. So we decided to include the questions for SDOH in our quarterly intake form, which was being created basically for the type 1 exchange to start collecting our patient data. And we decided to use the questions that the exchange recommended. We saw a presentation like at our first learning session from Dr. Lee, and we used those. So we did edit them. So here they are. So we unvalidated the tool, I guess. We added decline to answer. So that's kind of what people were saying. What if they don't feel comfortable? We gave them that option. And then to talk about how to manage people who didn't want to talk about it in front of their kids, we added that last question. Please check here to let us know if you would like to answer this in private. So then we would just not talk about it in the clinic, and we would call follow up. So I stuck a lot of our PDSA cycles on one slide here, and I have one more to kind of go over that. We too started with paper. It's the best, we started with one patient, we edited it, we gave it to more patients, and basically we learned the edits that we made was part of it. And then we realized we needed other options. We used REDCap, we made a REDCap link. Our end goal was to have it in EPIC on a MyChart questionnaire, and our goal was to provide it at all of our quarterly visits. And so that first stage was the paper form. Our social worker was tasked with making some resources, basically for transportation and food, because those were the focus of those questions. And then we started with our online option. So we sent the survey link via MyChart messages or email, whatever was on the patient chart. And those that did not have either email or MyChart, we just indicated it for the front desk to hand them the paper copy when they checked in. So I would say most, if not all, families did receive it in some way before their visit, but we still weren't getting them to complete it. Some weeks we were amazing, we had 80%, and some weeks we were closer to 15%. So we still were unable to pull that data, which is super important for the exchange and for us to just be able to track what we're doing. And we were also not getting people reporting positively. So we had some work to do. We decided to really push for the MyChart questionnaire, which would automatically assign. So we would take that off of really me and my other research coordinator from assigning it to people. And we created the welcome tablet questionnaire. We really need to shorten it. We're learning a lot still, and we need more resources. We also want to be able to provide resources to everyone so that if they're not reporting positive, but they should be, they can access those resources instead of just providing it to those people that report. So we did increase, obviously from 0%, we've done pretty well. But interestingly, you'll see, we went from the intake form, the paper form, to email. We were doing great. We were so focused on it. And like we were talking about this morning, once you kind of let it go, it does kind of go back down. And we thought welcome tablets was going to solve everything. They come in, the front desk scans that barcode, they're going to get it. And we've only gone down from there. So we need to meet as a group again and kind of start with one, as we talked about on Thursday at our QI meeting. And something else that I do have to say kind of happened at the same time as we started our depression screening. And we wanted to do that first. We want to be able to hand that to the patient. Like someone was talking about, we made the ID of the questionnaire to be a lower number. So that's basically the questionnaire that goes first. So that the front desk can say, this questionnaire is for the patient. Once they're done, hand it to mom and dad to do the rest of them. And so our quarterly, which was first, is now second. So, you know, we have work to do. But we did look at our findings. We only were able to look at the red cap because we do have not that many people who have filled it out on my chart. And you'll see that most people said never true. We did have, you know, a nice amount that said decline to answer. But interestingly, this last one says, would you like to discuss this with someone? And only 3 people said yes. So our social worker reached out to those 3 people. One had no idea what she was talking about. She clearly just like checked off something. And then the other 2, you know, she assisted in whatever way she could. So we have to figure out why, you know, we're in a very diverse area. We're in Midtown Manhattan, and we get people from all the boroughs, and there's got to be people we can support better. So in summary, we were able to increase our screening to 67% in July of 2022 from 0. And I kind of talked about all of our future initiatives, but we do want to work on capturing more people with these welcome tablets. It's such a great tool. It like a lot of work was taken off of my responsibility list, and it should be going better. So we need to kind of start with one patient again, and maybe edit it again. And I would love that wording to make it confidential, because maybe that's the problem. And we, you know, we want to include it in our diabetes education and our nurse that's meeting with every patient when they're triaged. So we have some ideas, but I've learned a lot today from everyone. So I hope to incorporate those too. And that is everything.
So thanks for that excellent talk. Do we have any questions in the room here from anyone? Oh,
No.
the question was, once it's in red cap, can it go directly to Epic? And the answer is no.
I think Red Cap and Epic would like to do that. There's like a lab one that can, like some lab results can be. There's a way, but the answer is no right now.
I think there was another question.
So I think people don't want to say that they have something going on, and you know, and similarly to the presentation that talked about, like, why are you asking this? Someone did say to us also, I don't want to answer that question here. I want to come in, you know, I love this team. That's not what I want here. I don't want to be asked that everywhere I go. And so if they're just available, we're hoping that maybe that could be useful. So I don't know. Yeah. Mm-hmm.
For them matters because a lot of times they're advocating to, I think, okay, I just told you, I didn't do this until it was on the field. And so, I mean, we have community health workers that are interested in do this, that you don't have to, but we basically tell them, listen, all of these really things are that we can evaluate, you know, help your, whatever your needs are, only your one are intimately intertwined, right? The intertwined. So we can't really know one without the other. And sometimes that rings through and then, you know, I don't know.
Right. Yeah. I think that telling them that it's potentially modifiable, like if we can, we will do our best, or even just to tell us that might be the intervention, like that we care about you so much and we know how hard diabetes is.
Like if I know that you have the tomorrow, I'm not going to go up and see you.
Right, I think that's a great idea. We have this digital signage and we're always thinking of what can we put up on this digital signage that can actually help people instead of like a picture of us with our, what we like to do. And so maybe that's it, like a little bit, diabetes is hard. And if you're struggling in other parts of your life, we have help for transportation or the things we can help, because a lot of it we can't, unfortunately, but except be there for them. But that's a great idea. Dr. Gallagher will love that.
So just for the virtual listeners, the key point there was that education for the families and the patients, that there are resources and other things that we can offer may help to encourage them to share some of their their needs with us. As someone who's at a center who I think we're at the 0% phase, so I'm admittedly relatively new to this. One of the things I was wondering for capturing those people who you might anticipate might need extra resources, has anyone looked at doing like the postal code mapping in terms of projecting possible need and maybe focusing, disseminating those resources to those populations?
Yeah, we did, I think for us, for pediatrics, it's like the Child Opportunity Index. And so you can look at that and see where people might need more supports. But we've only looked at it. We haven't done anything with it. But maybe
No,
that's
yeah, just an idea
like
that
to send
there's
out.
a lot of potential information out there that, even if you are not explicitly gathering it, maybe we have and can access people in need of more help in different ways.
Yeah.
Any other questions from the room or online?
I just have a question. You said you can give resources to everybody, or at least a list of it. Is it a list or a website, or what do you provide?
So we want to do that, but we don't have like a good way to do it. So we have, our social worker just made it. She made one with transportation, things that she can offer, ideas for them to go out and help, and food resources, like how to get food stamps or food pantries or wherever, things that can be helped with. We need more because that's not the only two things, but those are the two. We talk about food and transportation in our 4 questions. So
You share with everybody regardless.